And then also I will be monitoring the chat. So any questions that come up, please chat away and I'll keep my eyes on them. Okay, thanks so much.
Um, Thanks, Emily. It's really nice to be here. I always love starting the year and talking about this with you guys. I don't know where everybody is this morning, if you're like in team rooms or at home, but if anybody feels like putting on their camera, it's kind of nice sometimes to talk to faces instead of just blank names. But I'm excited today to talk to you about inpatient code status discussions. I feel like this is a skill that you're going to be using 4 to 5 times a day, every call day, and yet not something that has a ton of attention other places in our curriculum and can be a little bit awkward, an awkward conversation to start. So happy to be doing this today. And I also wanted to say this topic, I think, is a little bit different than, reading EKGs or reading chest x-rays or things like that, and kind of lends itself well to discussion and to your experiences and questions. And so I really welcome you to participate actively in the chat, if not just to unmute yourself and answer questions or share comments. I think it'll be a richer hour that way. So I don't have any disclosures. This morning, my goals are to talk with you about developing a clear approach to code status discussions in the ED. So while you're admitting a patient, when you finish your H&P, and ask that awkward question about whether someone wants CPR and mechanical ventilation. We're going to talk a little bit about what words you can actually say, how to phrase the questions and how to approach the conversation. How much time you should spend on these conversations. I feel like because CPR and mechanical ventilation brings up life and death kind of situations, I think some people tend to feel bad when they have a really short conversation. And also we don't have a lot of time for really long conversations for most of our patients. So figuring out how much time you need to spend with different kinds of patients to keep up with your call day workflow. Talk about when it's really important to understand someone's goals of care and not just have a code status order in the chart. Or, I'm sure you've seen a lot leaving people, full code by default or something like that, or a patient says, I want to think about it and I'll get back to you. But when is it important to actually understand more? And then finally, just how do you document your code status discussion in the chart so that other people can see the conversation you had and would inform that. And any other questions that you have along the way are also welcome to fit into this. As we're starting, I kind of just wanted to frame that a code status discussion is a primary palliative care skill. And primary palliative care skills are skills that all physicians should have, similar to the way that all physicians should be able to assess decisional capacity, even though psychiatrists might be most expert at it. All physicians should have these primary palliative care skills. First is screening and managing basic symptoms like pain, nausea, constipation, dyspnea, anxiety. I heard Gabby gave a really good talk recently about a start on all of these things. Second is a functional assessment and managing medical equipment that facilitates ADLs, and we often rely a lot on physical therapy and occupational therapy colleagues. Is someone maybe not muted? We often rely on physical and occupational therapy colleagues to help us with this assessment and figure out what might be helpful, help patients try out different equipment. Screening for psychosocial, spiritual, existential, and caregiver distress, though often management of those kinds of things falls to a palliative care team. And then finally, discussing and documenting advanced care planning stuff like a durable power of attorney for healthcare, advanced directives, and a POLST form. And so having a code status discussion fits into that last one, right? Advanced care planning kinds of stuff. I also want you to know that there is a lot of research that says that patients really appreciate good conversations about advanced care planning. And despite how awkward we might feel the conversation is, patients are really welcoming of this. So research has shown most patients expect their doctors to bring up advanced care planning when it's time. After all, we're the experts. We've seen many patients in similar situations, and we kind of know when things are serious and when they're not, and when it's time to start thinking about advanced care planning or end-of-life care. When patients bring it up, doctors often ignore cues about their concerns related to dying, often because we're uncomfortable with it. We don't know how to talk about it, or we feel like we failed them in some way by not being able to make them better or extend their lives. From other research, evidence does not suggest that patients have more hopelessness as a result of engaging in difficult end-of-life or goals of care conversations. And I think of this similar to the way, probably a more familiar example is, like, we don't feel that we encourage people by asking if they have suicidal ideation. And by the same way, we don't encourage patients to become hopeless about the rest of their life just by inviting a conversation about what's important to them and what their end of life might look like. For inpatients and their surrogates, there's a study that said specifically there's no difference in satisfaction with their care during a hospitalization, whether or not a difficult goals of care conversation has taken place. And then patients who have had advanced care planning conversations tend to be more at peace at the end of their lives, to receive less intensive care at the end of their lives. And their family members also tend to have a less difficult time with surrogate decision-making and grief. So these are all really, I think, facts to sort of bolster you in having these conversations, and knowing that, when someone is sick and coming into the hospital scared, these kinds of things are on their mind anyway, and it can often relieve some anxiety to talk about it. Before we get into a few cases, I also just wanted to say there is some research following residents and residents having code status conversations. And I think although this was in residents, I would venture to say that even in, fellows and attendings, this is similar. What we say is not necessarily what patients hear. And I think particularly if we go into a code status conversation feeling awkward about it or using euphemisms, it's like there's likely to be an understanding gap. And there's one study, although it was a long time ago, and I feel like palliative care education and you guys are just getting so much better at this over time. But one study that said that there was a huge discordance among patients and residents after these code status conversations had taken place about what was actually decided, what the code status was. And I think in 7% of cases, there was disagreement about whether or not the conversation had taken place at all, right? Which is a little bit surprising and shocking. So we're going to talk about how to make it explicit and yet feel comfortable, I hope. So I've got 3 cases to go over with you today, and different patient scenarios, and then a couple of trickier situations to talk about afterward. And this is where I'll start to invite you to open up your chat and get ready to weigh in. So this first case is a 64-year-old woman with a history of breast cancer in remission, hypothyroidism, atrial fibrillation on apixaban, and she comes in with a left lower extremity cellulitis. She's mildly tachycardic, otherwise her vitals are normal, and she gets IV fluids, IV antibiotics, and the left lower extremity ultrasound in the ED to rule out an abscess. And she has no advanced directives. Just think for a minute, how would you approach her code status, and how does it feel? Think for a minute, feel free to write something in the chat, and maybe we can ask for a couple of brave volunteers after a minute to share what you're thinking. Any takers? Anybody want to just unmute themselves and say if you're, you finished your H&P, she's here for something that's not that serious. She has no advanced directives. What are you thinking as you're about to transition to that part of the conversation and ask about her code status? What's running through your mind?
Hi there, my name's Nicole. I think when I talk to people in the ED about code status, I feel like there's two big things that can change like how that conversation looks. One is like how sick they are in that moment, and the other one is if they've actually thought about this before. And it seems like this patient hasn't based on their chart, but I feel like that's pretty inaccurate. So I would say low urgency to like have a very detailed, if this person's like, I've never thought about these things before, I don't know, I would definitely not push this in the ED with this patient, but maybe make a note to like follow this up later, because this person should, this is, we maybe have time in inpatient to like explore this over many days and come back to it and kind of help this patient have this before they leave. But I wouldn't say like, if with this patient hadn't thought about it too much, I wouldn't like press that in the ED. But if they've already thought about it and we don't know about it, then I would want to know, is kind of like my framework going into the discussion.
That's awesome. Awesome. Yeah. And Angela says maybe they have thought about it since they have breast cancer. I think that could be true. I think very few people get diagnosed with cancer and don't think about their mortality. It's just kind of a scary word. Yeah, thanks, Nicole. Thanks, Angela. Anybody else want to add anything? All right, let's keep going then. My thoughts are a lot like Nicole's, actually. And before we get into sort of nuts and bolts of it, I would say along the lines of Angela's comment that I usually start with some kind of framing, right? Otherwise, this is kind of a scary conversation to go in when we bring up CPR and healthcare proxies, ventilators. I think somebody, especially who's there with something not that serious, is going to think, why are we talking about this, right? Am I dying? Are you trying to tell me that things are much more serious than I think they are, than anyone else has told me? What are you not telling me? And it can kind of be a scary transition that you then have to dig out of a little bit. So some ways to frame the conversation. I sometimes transition from the H&P by just offering like a preliminary diagnosis and an impression of how sick they are, what the hospital course is going to be. So for this woman, you have a cellulitis. It's an infection of the skin and soft tissues in your leg. Because it's quite over a large area, you need to come into the hospital to get IV antibiotics, but probably within 48 hours, we're going to get negative blood cultures. You'll be able to transition to oral antibiotics and you'll go home and this should completely resolve, right? Then she knows we're not trying to have some subliminal messaging when we get to the code status part. I sometimes transition by asking if they have a healthcare proxy, right? I think that's like a more neutral question a little bit to ask, and maybe a more anticipated question when someone comes into the hospital that, someone would ask about an emergency contact. I usually start that way, say, do you have an emergency contact? And is that the person that you would trust to make healthcare decisions on your behalf if there were a time when you needed help with that? And then lastly, as Nicole kind of suggested, some kind of normalizing statement is another way to transition to say, I have another question for you that I ask everyone who comes into the hospital, no matter what they're here for, and then plop it out. Okay, so a few choices. I use all of those at different times, depending on the conversation, and things to consider just as you're transitioning. And then before we get into the nuts and bolts of the conversation, I just want to spend a minute to talk about what should actually be in the discussion that you have. What makes like a complete code status discussion independent of how much time you spend or how deeply you go into someone's goals? What needs to be there? And I think of a code status discussion kind of like an informed consent conversation for any other medical procedure, like a thoracentesis, paracentesis, a blood transfusion, right? And informed consent conversations talk about indications, right? Why are we suggesting this procedure? Why is this coming up? In what situation would it be useful? The details of the procedure, anticipated benefits, anticipated risks, alternatives, right, to the procedure. And then we usually end with some kind of recommendation. And I feel like for a lot of other medical procedures, like a blood transfusion, for example, the fact that we're having the conversation at all is kind of a recommendation that this person needs a transfusion, or like same thing with a thoracentesis, a paracentesis. The fact that we're talking about it at all means we think it's going to have some benefit that will outweigh the risks and should be seriously considered. Code status discussion is a little bit different, and we can talk about making recommendations later if you want to, or if we have time. But I think no matter how awkward you feel the words are that come out of your mouth when you start this conversation, I would bet that everyone is meeting all of these, checking all these boxes, right, of an informed consent conversation. One, this is what I hear a lot in the ER. If your heart were to stop, right, or if you were to die in the hospital, which are the indications for CPR, would you want me to do chest compressions and electric shocks to try to bring you back? Sometimes that involves breaking ribs or involves getting stuck on a ventilator. Or would you prefer that I let you die naturally? And then the recommendation part, we said we can talk about later, is a little more complicated. But I would say these words come out, can come out as like kind of jarring, right? And I'm sure you've heard conversations that have gone down just like this. And yet, as awkward as the words themselves are, you're hitting all the high points. So I think that's just something to note and pat yourself on the back for. When I approach a code status conversation, similar to Nicole, the first thing I want to know with a patient is, have they ever thought about this before? And some questions that I ask the patient to get a sense of whether or not they thought about this is, do you have any advanced directives I should know about? Or have you ever thought about what kind of medical care you would or wouldn't want if you were seriously ill? Have you ever talked with a doctor about things like CPR or being on a breathing machine before? And if someone answers yes, which oftentimes people do when I use the term advanced directives, the next thing I need to know is, was that conversation helpful, right? And to get at that, I ask, can you summarize for me? And sometimes people will say, perhaps with this patient would have said, yeah, I talked about this with my oncologist when I was going through breast cancer treatment. There were some times when I was really sick and they thought I wouldn't make it. And we kind of talked about it. And I have an advanced directive, in which case we know that sounds like it was a pretty informed conversation, and we can just use their advanced directive. But there are lots of patients who tell me sometimes, oh yeah, my daughter's a doctor, she's going to make all the decisions for me, or, you know, I have a will, it's with the lawyers. And like, that's not really what we're talking about when we mean advanced directive. So I put these people on the no side of the algorithm. And on the no side, if I find they haven't thought about this before, I then ask myself a version of the surprise question. Have you guys ever heard of the surprise question? Yeah, I only see Joanna nodding. Thank you, Joanna. Do you want to say what the surprise question is?
I remember correctly. I think maybe there's different variations of surprise questions. The one I've heard is, would you be surprised if this patient was like not alive in 6 months?
Exactly. Yep, that's the traditional surprise question. It's for, I think doctors to ask themselves about their patients and to think, if the answer to that is no, you're not surprised that this patient might die within the next 6 months, to consider getting them palliative care. That's the thing. In this context, I sort of co-opt the surprise question and think to myself, like, how surprised would I be if this patient had to transfer to the MICU or had a code, right, during this hospitalization? How likely is this to come up? And depending on, I kind of put patients in this bucket, like it's unlikely, it's possible, or it's very likely. And depending on how likely I think it is, that tells me how much time I need to spend on that conversation up front in the ER, when it's important to like really understand someone's values and not just their code status order, their code status decision. And when it's also important that we make a decision in the ER and not just present the topic and let them think about it and get back to us, when they can. Does that make sense? Yeah. Anybody have questions about this so far, or comments? Okay, I'm gonna go on. This second case is a little bit trickier. And again, I hope you'll weigh in. This case is a 72-year-old man with severe COPD who's admitted with new fever, productive cough, and acute on chronic hypoxia. This is his 4th admission for a COPD exacerbation in the past 6 months. He's on BiPAP in ED and an ABG is pending. And on his last admission, he was full code. So just think for a minute, how would you approach his code status? Knowing all this information about him, and feel free to type in the chat or unmute yourself when you're ready and just share what's going through your mind as you're getting ready to have this part of the conversation.
We can check his understanding of why he is on full code first and see if you really understand why.
Mm-hmm. Yeah, like did somebody just not talk about this last time? And so he's like kind of full code by default, or was that a really intentional decision? And Nicole said, yeah, he's already on BiPAP and not breathing well. He could be on event this admission. Yep. Joanna, tell me more about what you're thinking. A situation where we have to be careful not to put our own preferences on the patient.
Yeah, I think like this is a sick patient, like we can see that. And I think ideally, like what a lot of times in medicine, when we consider a good death, and I think there's a lot of literature on like physician moral distress, like we want this patient to not suffer and we want to like support them in what they want in life. But sometimes like what they want in life is like full interventions and they really want aggressive care. And like that causes a lot of distress for us, but just because it's uncomfortable for us doesn't mean we should like push the patient to like give up like interventions if that's what they want.
Yep, totally. I totally agree. And we're going to talk a little bit more about that in the future. But I think as healthcare providers, especially inpatient providers, we do tend to have a bias because we see people at their worst, right? We see people at their worst and we see all the times when it doesn't work out well, and we don't have as much context for the people who, you know, were intubated for 6 weeks with COVID and, you know, now 2 years later are totally fine, gardening, windsurfing, like one of my primary care patients is. So I think being aware of our biases, just like you said, Joanna, is really important. And Jessica, absolutely true. He may have difficulty taking off the, you know, being able to take off the BiPAP or being able to hear us in the ED and having a good conversation. And I think in that case, we're going to have to change the way we have this conversation to be in yes, no questions, right? So that he can nod or shake his head or identify a surrogate decision maker who can interpret his facial expressions, right? And be there with us. But there are ways we can do it. So again, when I am thinking about coming to this patient, I'm starting with framing, right? Of those things, do I want to give him an impression of how sick I think he is? Do I want to say a normalizing statement? Do I want to ask about an emergency contact first and kind of lead into it a little bit more gently? And then we want to know, has he thought about this before? Was his full code intentional or was it by default last time? Either way, we think it's a little likely that things may escalate this admission and we need to spend a little time here. So again, just to put this on the map, we talked about how our first patient with cellulitis, not that sick, right? Probably unlikely that a code or a MICU transfer is going to come up for her this admission. And this other guy with COPD is much more sick, much more likely that he might have to that he might be in the MICU or in the MICU have to be intubated and ventilated. So once you get to this point and you have a sense how much time I have to spend, what do I need to get out of this conversation? What words do you actually choose to say? And I'll just give you an example of what I say. For someone who's not that sick, I sometimes say, like, in an unexpected event where you died suddenly in the hospital, would you allow me to do CPR and place a breathing tube to try to reverse that? And you can fill in and adapt this language however you want. But I think the point that I'm trying to get across is they've never thought about it. I don't think it's likely to happen. And so what I'm doing here is getting assent to be full code rather than consent, right? And going through the whole informed consent conversation. Does that make sense? Hope so. Okay, speak up if it doesn't. And then on the other side, this patient who I know I need to spend a little more time with and have a more detailed conversation, I might say something like, you know, for many people with advanced COPD, there comes a time when, you know, even the best of our medical interventions can't reverse the damage that's been done to your lungs. I'm worried we might be near that point now, right? Pause, let him take it in. You know, I hope that with this oxygen mask and antibiotics and, you know, being in the ICU, that we'll be able to make you feel better and you'll be able to get over this exacerbation. But I also want to better understand how you feel about the situation you're in so that we have a good plan for what to do and how to take care of you in case things don't get better. That's how I kind of start. And then I set up this sort of scale in my mind, right, of where this could go. This could be DNR, DNI on one side, this could be full code on the other side, and how people feel about it. And if someone's never thought about this before, I offer them choices. And I say something like, you know, in thinking about the medical problems they have and what's important to them in life, I have some patients who would say, I'm satisfied with my life or my quality of life, but I have some serious medical problems. And if I get so sick that I actually die in the hospital, it was probably my time. So please make sure I'm comfortable, let me go, and whatever else they want to add, right? Be near their family or whatever. But if I get that sick, it was probably because it was my time. And then I have other patients on the other end of the spectrum who would say, I value as long a life as possible. If I get so sick that I die in the hospital, do whatever you have to do to bring me back, even if it means more pain or suffering, or that I might not have the same quality of life that I had before. And for those people, I think of them, they're going to be full code. In the middle, which I think is honestly the majority of people, I have some patients who say, I want to live as long a life as possible, but only if my life is of a certain quality. So do your best to bring me back. But if it seems like I'm not going to really get better, then talk to my family about letting me go. And I think in this bucket, I think of people as full code with like a time trial, right, of intensive intervention. And I don't know if you had anybody heard of a time trial. Nope, time trial. Time trial before is where we sort of make an agreed upon plan of care, often for some more aggressive intervention, and we try it for a period of time over which we expect to see some change, if there's going to be a change, right? Positive or negative. We say, if this is working, then we'll, at the end of our trial, we'll know and we'll continue on that path. And if it's not working, we'll know we tried. And at that point, we can change our decision, right? And so I think all these people in the middle category are the people who say that they don't want to be a vegetable. I'm sure a lot of you have heard that when you ask about CPR, that they say, oh, you know, well, I don't want to be a vegetable. And what do you do with those people? I think they're saying they're full code, right? They're not telling you they don't want you to try. They're saying that they're afraid of having a bad outcome. So I think of them as full code, but we're not going to leave them indefinitely on a ventilator because that probably wouldn't be acceptable to them. And so just in putting people in buckets like this, I start to think about what values are behind these kinds of statements. For somebody who, you know, is saying the statement aligned with maybe DNR, DNI, I know that they really value their quality of life and maybe comfort over longevity. For somebody that's saying, bring me back no matter what, I know that they really value their longevity over other priorities. And in the middle, these people who want kind of the best of both worlds or who are worried about being a vegetable, I know that there's some kind of balance that we're trying to strike. I also just want to take a minute to talk about goals of care versus goal concordant care, because I think when we're having more in-depth conversations with patients and figuring out what is right for them, what is the right intervention for them, these terms come out a lot. I'm wondering if anybody, you know, was willing to unmute themselves and just help define these. What are goals of care and what is goal concordant care and how are they different? Okay, maybe this is good. We're talking about it. I'll say goals of care. I think of the goals part in goals of care as the most important word in that. When the goals of care means in the setting of an illness, what is most important for this patient's life, not for their medical treatment, for their life. And that could be remaining independent, could be being comfortable, could be time with family, living as long as possible, not being a burden, finishing a project, a bucket list activity, going on a vacation. I had a patient that was all about fishing, right? His goal was to like fish on this pond where he grew up as much as possible. And all of his medical care was oriented toward that goal. And then goal concordant care being the most important word in that statement, is a little bit different. And that is the medical treatment that will help a patient achieve their stated goals, which are usually non-medical. Does that make sense? So you get patients say, in this situation that you're in this reality that you're in, what are you hoping happens from here? What do you want to happen in your life? And then I offer medical options that will help you meet that goal. Does that make sense? So we're providing the goal concordant care. Patient is telling us what their goals are. And for patients that do choose, I think I'm kind of imagining that after a conversation, this patient with COPD may choose less, right? Because he's kind of coming back to the hospital time and time again and really not necessarily getting far with the interventions that we have. I also just want to make very clear and plain, and maybe this is for you also to speak up to your attendings and your medical team, that DNR is not a philosophy of care. And there's this great quote in a book by Steve Pantelat, who's a very well-known palliative care doctor at UCSF, who kind of explicitly says that DNR is a code status order. It's not a statement about how a patient feels about their life or their illness or their medical treatment in general. And in this book, which is written for patients, he says, the challenge is that many people, doctors and nurses included, think that no code and DNR mean do nothing. That is, don't do anything to help patients live longer, which is simply not true. In reality, no code and DNR only mean that if you die suddenly, we won't try to revive you. It doesn't mean anything more. It also doesn't tell us anything about your preferences for any other treatments, and we can do plenty short of CPR to help you feel better and live longer. And I mention this just because I think some patients and our family members are afraid to choose DNR or DNI status because they think healthcare providers are going to see that in their chart and assume that they're okay with dying, or they're okay with less, or that their goals are not that aggressive. And this is just drawing a line. A DNR or DNI is just drawing a line at one of the most intensive medical treatments we have, right? Which often doesn't have as good outcomes as we hope for. But this does not mean that a patient doesn't want surgery, doesn't want dialysis, doesn't want lines and pressors in the ICU. And so all of that stuff, just to remember, is still on the table. And with that, I'm going to go to our last case. This is a patient that I actually had at Harborview, a 101-year-old woman who comes in after a fall. The fall was most likely mechanical, but she was found to have a detectable trope, and she's being admitted to cardiology. She has no chronic cardiac or pulmonary problems and no cognitive impairment. Her husband, who's at bedside, recalls that she has a pulse form at home, and I don't think it says DNR. How do you feel about her code status? How likely do you think a code would be for her this admission? And how would you respond to something like this? Feel free to use the chat too. Okay, well, I'll just say I entered a full code order. How frail she is. Yep, Joanna, I think that's also important. I entered a full code order into her chart because she had a pulse that said full code. And And I got paged immediately by one of the nurses who thought that was ridiculous and probably really pushing her luck. And the reason that I entered a full code order is because I asked her husband, how did you come to that decision, right? How did she come to that decision? And he told me, you know, she has just aged so gracefully. And there's so many things that she used to do that she can't do anymore. And it doesn't bother her at all. She just finds different things, right? She just finds different things to do. And, you know, she's still really engaged with her family and friends, even though she doesn't go out so much. And she's just, you know, she doesn't complain. She's not bitter. And so she wants to be around for as long as possible. She's enjoying her life and she wants to stick around. And whether or not we think CPR is likely to help her, right, or likely to work for her. The point is she has thought about this, right, in an informed way. And it sounds like if she did have a bad outcome, she might handle it pretty gracefully, right? Or her family is prepared to help her handle it pretty gracefully, whatever that means to them. And so I just wanted to also say, again, to check our biases, and it is totally okay to be full code, I think, and especially this is not necessarily the hill for us to die on. What's important to remember is that if somebody's code status decision surprises you, spend the time, try to understand their values, and make sure you understand their decisions. Okay. Now, as we're talking about all the options that people have for code status when they're in the ER and you're having this conversation, I'm going to look at all these different options because I see all of them on Pulse Forum sometimes, and just ask, feel free to put it in the chat, which one doesn't belong? Totally. Number 3, that one doesn't work. Somebody want to say why? Maybe Kayla in the chat. Or sure, I'm listening. Whoever. Yeah, I can't see.
I was just going to say you need to secure an airway as part of like ACLS, BLS pathways.
Yeah, I usually tell patients that, like, if your heart is not getting oxygen, CPR is not going to work. Right. So if your heart stopped, that means you're not breathing. And if we can't get oxygen to your heart, CPR is going to work. There's no point in going through CPR if you're sort of handicapping yourself, right? Or holding yourself back by not giving oxygen. So those things have to go together. And I'm glad that it was apparent to you. I see that often on post forms that people choose CPR without intubation. And I understand why CPR could seem less invasive, and for somebody who's trying to avoid something invasive, but it doesn't work, and I don't offer that. Okay. I wanted to spend a few minutes also talking about some tricky situations that come up with code status. I think all the cases that we just talked about, right, when you're admitting someone from the ER, how to have the conversation, whether someone is not that sick and you can have a short conversation, whether someone's sicker and you really need to go into it, or whether someone's code status really surprises you and we need to check our biases, but as long as we understand they're thinking it's okay. I just wanted to spend a couple minutes on some 2 trigger situations that I think come up more often in the ICU. Maybe when someone, not when you're admitting someone, but maybe when someone's transferred into the MICU and their code status might need to be changed for some reason because their clinical status has changed, and want to empower you some thoughts. So I think most of these tricky situations over code status happen when a patient or family member wants interventions that the medical team feels are inappropriate. Right. And we already talked a little bit about our biases, but even after we check our biases, I think we have some expert knowledge, right? And that's why that informs these situations. And I think it can be difficult when we have a patient and family asserting one thing, our expert knowledge guiding us in a different way, and maybe nurses or other staff in the ICU and all that they've seen in their training and their moral distress, because they do a lot of CPR hands-on, how they feel about it too. I think in these situations, it's really important to understand for everyone, for yourself, for the medical team, but also for patient and family nurses, why they feel the way they do. and also what logic they're using to inform their choice, right? I hope most of the time, as medical providers, we're using Western medical science, right, to inform our recommendations. Patients can use that. They often also use their faith. They use a patient's previous healthcare experiences. I mean, maybe someone has survived many, many things that doctors told them they wouldn't survive, and yet they have, right? Or maybe they're just afraid. This is a big decision to make, and fear could be in the way of making a choice. I think having an understanding of where people are coming from and why really reduces moral distress and helps build trust. I think especially in my work in the past with ICU nurses, right, being able to explain to an ICU nurse, why are we going to do CPR, even though it doesn't feel right to us, allows them to sort of shift their perspective a little bit and maintain their compassion for a patient who maybe just sees things differently than we do. And I think when we can't do that and we have a standoff, it just results in more suffering, right? For patient, for family, for nurses, for us. And that's a lot of where moral distress comes in. And two ways that these standoffs kind of can show up that I want to just call out are slow codes. That's one of them. Have you guys heard of slow codes? No, anybody? I'll actually be thrilled if you've never heard of this. I guess that's a no. That's a no. Slow codes. I'm actually thrilled that you've never heard of this because they are widely considered deceptive and unethical. Slow codes are situations where a family is dead set on having CPR. As a medical team, we think that's the wrong decision. We think there's no hope that it's going to work. And so a medical team sort of acts out a code blue situation without doing effective chest compressions, without necessarily intubating somebody, without giving the ACLS drugs on time. And you can imagine just, if someone's like, doing CPR like on TV, right, how that would be ineffective, right? We know that for CPR to have a chance, you need 100 to 110 chest compressions per minute, a depth of 2 inches, defibrillation as quickly as possible, all of that kind of stuff. So if we're doing CPR, it's very agreed upon widely now that if somebody's doing CPR, we're giving it our all. I think because people tend to know so clearly that slow codes are not acceptable, we sort of move into this framework where I think a lot of people bring up the idea of medical futility, right? I still don't want to do a code on this patient. I'm going to, invoke this concept of medical futility to sort of absolve me of having to do that, and of sort of coming to a consensus with the patient. Have you guys had any situations on rotation so far or in medical school where people invoked the concept of medical futility? I heard somebody maybe trying to say something. No, Kayla said no. Any idea what it is? All right, great. Glad we're talking about it. So medical futility, I think, is a term that people sometimes, will throw around to say, this person is so sick. I think there's so little chance of XYZ intervention working or CPR working. It's futile to do it. So we're just not going to do it, independent of what the family says that they want. And I think this is tricky for a lot of reasons. One, we have to be really careful. There's no legal definition that I know of medical futility. It's not like once you cross a line, the care is futile. Like decision-making capacity, medical futility is intervention specific. So it's not like everything we're doing for this patient is futile because they're going to die. It's maybe saying, this doing CPR, right, might not benefit the patient, right? Or intubating this patient might not benefit the patient. Adding another pressor might not benefit the patient, whatever it is, but it has to be intervention specific. And it has to relate to benefit to the patient, not just physiologic effect. So obviously, if we add another pressor for a patient, right, in the ICU with septic shock, it may make their blood pressure go up. Whether or not that will have a meaningful, result in a meaningful change to their overall status is different, but just changing their blood pressure alone may not be enough to actually give benefit to the patient. So we're looking for a benefit, not just a physiological effect. As you can imagine, benefit is totally subjective, right? What we think benefit is to the patient, right, I think is often biased and limited to their physical health condition. And family or a patient might not see it that way. And I think there are some things that we very regularly and without any angst consider benefit, like when we continue interventions until a family member from far away can come and see a patient who may be close to end of life, for example, right? Like continuing mechanical ventilation or continuing pressors at that point may not change their outcome, but it may allow them to see a family member, right, who's on their way. I think that would definitely be benefit, but that's just one example of how the benefit is totally subjective and people can disagree. And so it's really helpful in this situation to understand someone's goals, right? And again, if they say, my goal is to see this family member, or my goal is to, be able to sit in a chair, or my goal is to be able to eat solid food, like how can we make that happen with the medical interventions that we have? And then finally, just to know, the principle of patient autonomy means that patients can choose from medically appropriate options, but it doesn't mean that they are entitled to choose the direction of their care, right? And so we are not obligated as medical providers to offer interventions that aren't appropriate, right? We offer options that are appropriate to the situation, and patients get to choose those. So I just wanted to give you a little bit of background on that in case that comes up for you in the ICU or when somebody is changing their code status. There's a wonderful sort of introduction / FAQ about medical futility on the UW Department of Bioethics and Humanities website, which I put a link to at the bottom, that kind of just explains a little bit more about different situations that can come up around this topic and how people use this term, how to sort through tricky situations that come up with it. Anybody have questions about that? No. Okay. These situations, I guess, was just also going to say a good reason to consult palliative care. Okay, the final part of this talk, I just wanted to talk about how to document your advanced care planning conversations. For post forms, I hope you've all seen a post form at this point. They have a couple of mandatory boxes on the front page and then some optional ones on the back page, and basically ask you to choose CPR, yes or no, mechanical ventilation, yes or no, transport to the hospital, yes or no. I think for patients who are full code, I don't think it's terribly important to have a PULSE form, right? Because that's the default. But for patients who want to be DNR and or DNI, it's really important to have this form. And I think of this form as like kind of a protective shield. When they leave the hospital, they're like, this is the thing that will allow medics to treat them the way that they want to be treated rather than the default, which is CPR and intubation. When you're documenting your code status discussion in EPIC, best practice is to include, all 5 of these things that I've listed, who the discussion was held with, what the patient's goals and values are, their prognosis, treatment options and resuscitation outcomes, who their healthcare power of attorney is, to discuss all of that stuff. And you can see in the graph on the right, most code status conversations, documentation doesn't hit all the high points. Most conversations actually hit none of them, but I'm bringing this up hopefully so that we can do a little bit better. And I think the important point here is just to document whatever you actually talked about, right? Because sometimes, a patient, you may be able to have a conversation with a patient this time when they're in the hospital, and next time they come in and they're, unresponsive and alone, and it's really helpful to know what they've discussed in the past. So whatever your conversation is, whether or not it has all those elements, just write down whatever you discussed. Some examples. I had a conversation upon admission with Miss R and her husband, her DPOA. She has advanced ILD. She feels her quality of life is compromised significantly by her dyspnea. And unfortunately, she's not a candidate for lung transplant. She'd like to maintain as much independence as possible in the time she has left. And given that CPR and mechanical ventilation would not help her achieve this, she prefers to be DNR or DNI. One example. Another example, I had a conversation on admission with Mr. T and his son, his DPOA. He has end-stage renal disease that is stable on hemodialysis. He's grateful for dialysis extending his life and has adapted to the intensive treatment. And he would readily accept other forms of support and associated burdens with the goal of more time with family. So he prefers to be full code. That makes sense? Yeah. And whether or not you hit all these high points, just write down whatever you had. So some take-home points, approaching code status discussions in the ED. Make sure you frame the clinical context so it's a little less jarring when you're transitioning from your H&P to this. And you can do that by asking for someone's DPOA, using a normalizing statement, offering an impression of how sick they are and what do you think is going to happen during the hospitalization. Consider using the algorithm to talk about, or to decide what depth of conversation you need to have, what words you want to say, how much time you need to spend. Make sure to elicit values like someone's goals when making decisions, and allow them to set the goals, let their goals based on their life, right? You bring the expertise about the medicine, they bring the expertise about themselves. And then finally, just document your discussion, whatever it happened to be. I want to leave you with a few resources. One, you're welcome to email me anytime. I love talking about this stuff, obviously. And if you are interested in sort of a little bit more about advanced care planning or palliative care in general, some great resources. The Vital Talk app is an organization that helps with patient communication. They have an app that has some just-in-time teaching for, how to deliver bad news, how to reframe, when someone is sicker than expected, how to recover a relationship with a patient, if you've found yourself in a bad spot. The Conversation Project is for patients and kind of coaches them on how to have conversations about advanced care planning with their loved ones, how to select a power of attorney. Same with prepareforyourcare.org. And then finally, the Jerry Powell podcast is one that I listen to a lot in residency. It's put out by 2 geriatrics and palliative care doctors at UCSF. And they review a lot of up and coming stuff in the field and have interesting conversations about it. That's all I got. Thank you. Nicole. Okay, so any questions? Yeah, feel free to stick around if you have some. If they don't have a legal DPA and their preferred person to make decisions isn't the default by law, how do we legalize this for patients in the inpatient setting? You can just bring them a form. Does that work?
Doesn't need to be like notarized or anything. Like they just have to fill out a form and then if we upload that, then that's all they need.
Well, that's a great question. I haven't seen the Washington DPOA form for a long time, but I think there is an option if not notarized, to have 2 witnesses instead. And the witnesses could be anybody in the hospital who is not involved in their care. So it could be like another nurse on the floor, could be, a PCA on the floor, a consultant that walks by, who just walks in and meet them and say, yeah, this is your form. This is how you, okay. And can sign it.
Yeah.
Amazing. Thank you so much.
Yeah, I'll also add, you can sometimes a good question for the social worker to help with too. So if you don't have the bandwidth to do the forms with them sometimes, and it's like during the day, you can ask the social worker to help. I think at night and like over the weekend is when it can be a little complicated.
I think if a patient can state their preferences, though, that's pretty clear.
Yeah, thank you so much. That was awesome. I think people are logging off, but please feel
Gotta
free.
go. Yeah. Yeah, I can stick around for a couple of minutes in case other people have questions, but otherwise have a wonderful day, wonderful week. Thanks for having me. Bye, Emily.
Bye, thanks so much.